Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Hello and welcome to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, board-certified fertility doctor, and this show is all to help you understand your fertility, your hormones, and beyond. Today we're talking about AMH testing, ovarian reserve testing, and understanding what that means, what some of the results could indicate, and generally just helping you understand your body better and become a better advocate for your own health. Before we dive in, I just want to go over a few housekeeping items. First of all, huge thanks for all of your support on the podcast, all of my content, the YouTube channel. I'm just so thankful for all of you guys for listening, for sharing, for helping other people also become advocates for their own body. Podcast is at over 5 million downloads and strong, and that's just mind-blowing. I love it. So thank you so much. Next is that I love answering your fertility questions, and I know sometimes you have a lot of them. There are different ways that you can ask your questions. So you can ask questions online on Instagram at nataliecrawfordmd every Monday. Some questions will be answered on Instagram, some will be saved and answered in the weekly newsletter, and some will be answered here on the podcast. For the weekly newsletter, not spam, it has my favorite recipes, updates, fertility questions answered, little tidbits. You can sign up for that newsletter at nataliecrawfordmd.com/newsletter. You also can call and leave a voicemail question. The voicemail is absolutely one of my favorite things, and you're going to be hearing some of those voicemail questions today integrated into this episode. The voicemail is 657-229-3672. Again, 657-229-3672. And one disclaimer, I'm getting over a cold, so if my voice is a little scratchy, I apologize. We will try to get through it. Before we answer some questions and go into some of the nitty-gritty, I think it's really important to talk about what ovarian reserve is and what it is not. You might hear me talk about the vault inside your ovary, and this is the analogy I created to help my patients understand what's going on. So if you imagine your ovary has a vault inside, that's where all your eggs are kept. When you are born, that vault is full. When you go through menopause, the vault is empty. So imagine that from the moment you're born, a group of eggs are coming out of that vault. In reality, those eggs are coming out before you're even born, but we'll just go from the moment you're born until menopause. Each egg grows inside a follicle. So what is happening is you have a group of eggs or follicles outside the ovarian vault. Now, these eggs cannot grow unless they are stimulated. So when the brain sends out a hormone called FSH, follicle stimulating hormone, that hormone works to stimulate one egg to grow. That's its job. Just enough FSH is sent out to get that one egg to grow. As the egg starts growing, it actually makes estrogen. All your eggs at baseline or in their quiet state before they grow make a tiny bit of estrogen. Let's call it 1 picogram. A mature egg that's ready to ovulate makes much more estrogen, example, 200 picograms. So you can see that the bulk of estrogen production comes during the process of the egg growth getting close to ovulation. So FSH stimulates a follicle or an egg, so it's well named. That egg starts growing, making estrogen. That estrogen comes and tells the brain, hey, an egg is growing. And what that does is the brain will now decrease the amount of FSH that it is sending out. And you will just have this one egg continue to grow. When your estrogen does get high enough, so 200 picograms for 50 hours, that is the sign to the brain that the egg is mature. I always like to think about the brain and the ovaries being best friends that live in two different states. Like my best friend Chrisley, she lives in Georgia. I don't know what she's doing unless she tells me. So the text messages she sends me help me know what's happening in her life. This is like the brain and the ovary. Hormones are the text messages. So as the ovary is making estrogen, it's telling the brain an egg is growing. And when the brain is sending out FSH, it's telling the ovary, hey, time to grow an egg. This allows for interference. Different things can allow you to misread a text message or for it not to go through completely. Have you ever gotten a message from your best friend and you didn't know what they meant? Or you read it the wrong way because you can't interpret tone? Similar things can happen in between the brain and the ovary. But when the system is working perfectly, the ovary is making estrogen. Estrogen tells the brain an egg is growing. The brain stops making FSH. When the egg gets to that mature zone of 200 picograms for 50 hours, that's the signal to the brain that it's mature. And the brain will send out the LH in a surge. So a huge surge of the hormone LH, or luteinizing hormone. And this is the hormone that allows you to ovulate. Ovulation is the follicle rupturing, egg being released, follicle reforming, and then that follicle is making progesterone, stimulated from the brain. One important takeaway is that progesterone is not made in a constant state. And I probably talk about this weekly, if not daily, with patients because a lot of healthcare providers, doctors, nurses do not understand, and a lot of patients do not understand. But progesterone in the luteal phase is released from the corpus luteum in a pulsatile fashion, meaning as the brain sends out pulses of LH, now the corpus luteum, which is that follicle that resealed again, will make progesterone in corresponding pulses. So any amount of progesterone that you check is just telling us about how your progesterone is right this minute. It's not telling us about the adequacy of your luteal phase. It is a yes, no. Did you ovulate and now we see progesterone? Or did you not and now we don't see progesterone? If you get pregnant, that pregnancy will come an implant and it starts to make HCG. And HCG is that pregnancy hormone. HCG and LH bind to the same receptor, so fascinating, and it can stimulate constant progesterone production. And a normal pregnancy has a rise of HCG that's exponentially getting higher. Therefore, the corpus luteum is getting a constant and stronger signal to make progesterone. And that's why you see a big bump in progesterone production once you get pregnant, and all the associated symptoms of having high progesterone. And a huge fault here is people using what we might want to see in pregnancy levels as what we should see in the luteal phase. But that's not what happens naturally. In nature, pulsing progesterone until a pregnancy implants, then you have a rise of progesterone as HCG rises. If you don't get pregnant, then what happens is your progesterone is going to drop. The corpus luteum can only live for about 12 to 14 days. So after 2 weeks, no pregnancy, corpus luteum dies, progesterone production stops, levels drop, signal to the uterus, hey, nothing happened, and you're going to bleed, that's your period. And all of those follicles that never made it to ovulation have died. And you're going to have a new group of follicles ready to receive a new FSH signal from the brain. So you are constantly losing follicles every single month. Even before you start your period, what is happening all of those years is that puberty is turning on FSH and LH from the brain. You don't have those hormones made pre-puberty. So eggs come out of vault, no FSH, all the eggs die. Next month, another group. And if you're on birth control pills, same thing. The birth control pill works by telling the brain to not send out any FSH. So now you have a group of eggs coming out of the vault, no FSH is being sent out, so they all die. Next month, another group. What's so fascinating about this is that you have more eggs sent out from the vault when you have more eggs remaining, and you have less eggs sent out from the vault as you have less eggs remaining. If I tell you average number of eggs outside the vault at any given time, at age 30, it might be 20. At age 35, it might be 15. At age 40, it might be 8. And at age 45, it might be 3. So you can see that you have a different number and it's exponentially decreasing as you're getting older, but that those eggs outside are a representation of what you have left. Also importantly, you can run out of eggs early. The youngest patient I've ever seen ran out of eggs before puberty ever started. Never had a period, came in to see me, was an ovarian failure. It can happen. It is rare, not common, but it can happen. I've also seen young women in their 20s run out of eggs. So it's one of those things where we can say, yeah, you're young, but unless we know what's happening to you, we can't say with full assurance that you're not running out of eggs. An important concept is that when we are measuring those eggs outside the vault, we can count them. That's called an antral follicle count. You can also do a blood test called AMH or Anti-Müllerian Hormone. AMH is made from the cells that surround each follicle. Those are called the granulosa cells. And the more eggs you have, the more granulosa cells, the more AMH. The fewer eggs you have, fewer granulosa cells, lower AMH. You get the picture. What's a couple interesting ideas is that I like to imagine AMH is living in your body a little bit longer than that one-time look. Let's just use the example 3 months. So let's pretend that AMH is giving us a 3-month look and your follicle count is giving us a one-time look. This is important because your body's not perfect. Let's say that you're an average 30-year-old. What I might expect to see is that you're going to have 1 month 20 eggs, 1 month 22 eggs, 1 month 19, 21, 17, 20. So you can see that each month it is a little bit different depending on just the month. And we know that it can be almost a 30% swing month to month. So it's helpful, and certainly seeing a number that's normal or higher is reassuring. But if it's low, I want you to realize that it could be just a random bad month. That's what we hope. It could be a little bit lower than normal. It also could be your very best month, and your reality might be lower. And that's why doing an antral follicle count and an AMH are helpful in understanding where you might stand on this pathway. And of course, there are certain things that can influence. Namely, if you have not ovulated in a very long time, sometimes your granulosa cells just start making less AMH. It doesn't mean your ovarian reserve is truly low, but it might be an induced lower state because of the suppression. A good example of this is breastfeeding or birth control pills. These are circumstances where you want to see a doctor and talk about it. If you're on the pill, for example, sometimes we stop it, repeat in a few months. Sometimes we don't. It just depends on your situation and your goals. A couple other things about AMH before I answer some of your questions. One is that ovarian reserve testing, screening to see if you're running out of eggs is not something that is routinely done, and it's currently recommended against. I'm not a supporter of this. I stand with my medical organization on the vast majority of things, but I honestly think this one is wrong. I think they say this out of fear that a low AMH or follicle count will make somebody upset or act towards fertility treatment that they may or may not need to conceive. But we're making a lot of generalizations. And one of my favorite things to say is that you can't make decisions on data you don't know, because who knows what you'll do in that position unless you get the opportunity to make the choice. Fertility, your future, there's so many variables at play, but it's the worst when time makes the decision for you and you never got to make the choice. I am a fan of ovarian reserve testing in people who either have symptoms or signs that something may be abnormal or they may have infertility, known factors that may impact their fertility and they want to have kids now or in the future, or somebody who wants to have kids and is waiting for whatever reason, because you could do something different. You might be able to freeze your eggs. You might be able to change your plan. You might be able to start trying sooner. You may do none of those things, but you don't get the choice if you don't know. Having low ovarian reserve does not mean you cannot get pregnant, and I think that's a very important concept. If we just think about you have 10 eggs, your best friend has 20 eggs, you're both ovulating 1 egg per month, You're losing different numbers. You're losing 9 eggs. Your friend's losing 19 eggs. Your longevity, your fertility window is probably less than your friend. You will probably run out of eggs earlier. But that doesn't mean that that egg can't be fertilized and you can't get pregnant. I hate, though, when people say, oh, having a low AMH 100% means you don't have infertility, or we say low AMH is not associated with infertility. Because I think it is a little too broad. Meaning, why do you have a low AMH? I don't love coincidence. Why do you have a low AMH? Is it because of endometriosis? Well, that certainly can cause infertility. Is it because of an autoimmune disease? That can cause infertility. Is it because you smoke cigarettes? That can cause infertility. So I think it's important that, yes, some people are just born with fewer eggs, or they run out of eggs at a faster pace and may have a low AMH or low ovarian reserve, and it might not impact their fertility as long as you're still ovulating. But you also could have a reason for your low reserve that absolutely could cause you to have infertility and might drastically change your future, your plan, your treatment. Last thing I want to say is that normal is relative to your age, meaning if you are older, your range of AMH is lower, but if you're younger, it should be higher. One other error I see is that somebody will get an AMH checked at age 30 and it'll come back at 1.2. And they look at the normal range for the lab and it's in there, so they say no big deal. But for age 30, an AMH of 1.2 is low. That's not normal. I would expect you to fall more in the 2 to 4 range. So when we're falling off of the average for our age, that is also important. And that's why using lab references is not always the right answer, because it doesn't know your exact situation. So I know testing ovarian reserve, AMH, getting ultrasounds, it is an essential part of a fertility evaluation. I always think that it would be something great to discuss with your OB when they ask, hey, what birth control do you want? Are you trying to have kids? If you say, hey, I don't want them now, but I really want them in the future, that's a goal. Could we check an AMH? And they might say, hey, it's not recommended. We don't usually recommend screening. And you could say, I totally understand, but it would really help me make some decisions. And if it's abnormal, I'll go see a fertility doctor and talk to them about it. But it would really help me right now. And that's reasonable. That's all your OB wants to know, that you're not going to hold them to the fact that it doesn't mean you can get pregnant or you can't, doesn't reflect your fertility, isn't recommended, but it might be valuable information to you. So I recommend, if it's something you're 30 and older, you want to have kids, that's written on your life goals, and you're not ready now, consider asking your OBGYN for ovarian reserve testing. You also can come to a fertility doctor. We see patients, we do testing, we talk about fertility, we talk about egg freezing or embryo freezing. So you also can schedule with a fertility doctor. But the easiest thing is to bring it up to your OB at your annual visit. I'm going to answer some of your questions about AMH because I can sit here and tell you all the things I know about it, but I know that specific situations still leave you with questions. So let's answer a few of your ovarian reserve questions now.
Hi, Dr. Crawford. Thanks so much for all you are doing for the infertility community and all the information you're giving. I have a question. I've kind of confused myself after looking online. I just had a transvaginal ultrasound, and the tech told me that he was seeing about 18 follicles on each side. So I'm curious, does that mean that my antral follicle count is 18, or do you multiply that by 2? And then she also said that is a bit high. I am 31, almost 32, and my AMH, I believe, is 2.7. And I don't have any of the other symptoms that are commonly associated with PCOS. I've always had super regular periods for my entire life, not being on hormonal birth control. and none of the other symptoms track. So I guess I'm curious, is that normal? Is that a high amount? And are there any other things that could be causing a high amount of follicles? Thanks so much. Hope you're able to answer my question. Bye.
Okay, so great question. Number one, you have 2 ovaries. We count the follicles on each of them, add them together, and get your follicle count. So in this case, 18 plus 18 equals 36. Now, that is high. In your age range, I would expect to have around 20. So having 36 is definitely above average. Your AMH is in the average range though, so these two things are a little bit discordant. That's okay. It happens. As we said, AMH can fluctuate, so can your follicle count. I would always rather it fluctuate higher than lower, but it does make me curious of a couple things. How long has it been since our AMH was checked? Was the AMH checked on birth control? I know you said no, but just giving people things to think about. And when it comes to the tech, are we certain they said it was 18 on each side, or was it 18 total? Just things to clarify. Typically, at levels where you have 18 follicles on each side, I would expect an AMH to be higher. That is a little bit more consistent with potentially PCOS, but sometimes that's just how the randomness of that month fell. One of the concerns when you have a high AMH is that your body may not be ovulating regularly, and the way that I think about this is a high follicle count can confuse the brain. Best friends, different places. So if the brain doesn't know that there's 36 follicles and it sends out just enough of a signal to get 1 out of 18 to grow, that signal is going to be diluted amongst 36. And in that circumstance, it's not strong enough to get any follicle to grow, and you might find yourself in a pattern of not ovulating or very long cycles where it takes a follicle a longer exposure of FSH in order to kickstart into growth. And this is what we often can see in patients with PCOS, is that the higher their follicle count goes, sometimes what we see is that we have worsening irregularity or lengthening of our periods or amenorrhea. But if we're having perfectly regular periods, we had a high follicle count, have a normal AMH, I wouldn't worry about it. It might impact my protocol if I'm doing fertility treatment, but it's not something that is reflecting an underlying problem in the absence of other symptoms.
Hey, Natalie, thank you for all you do. It's really been a wealth of knowledge and helped me throughout this process. I recently had my AMH drawn, and the labs portal says that my AMH was out of range. It was 9.07. And then my doctor posted it to my regular patient portal and left a message saying it was within normal range. I'm just really confused and trying not to go down a rabbit hole of Google. But if you could just provide some clarification on if it is out of range, if it's not, or what kind of treatment would be involved with an AMH at that level, or if it needed to be treated at all, I'd appreciate it. Thank you.
At any age, an AMH of 9 is out of range. It is definitely high, meaning we don't see that and call it normal. This can be so frustrating. I know when maybe doctors are trying to get something across and it comes in the portal and you have questions. And I know not every office is set up to give you the best information. But in general, it's not as problematic as having a low AMH. And it's not a problem at all unless you are having issues. Meaning an AMH of 9 is highly suggestive of PCOS. Very much so. In fact, some places are starting to look at AMH levels this high as even diagnostic factors. When it comes to PCOS, what does that mean? Well, if you have perfectly regular cycles, it doesn't mean much at this exact moment. You might want to learn a little bit about PCOS because I always talk about PCOS patients being highly sensitive to inflammation and really benefiting from anti-inflammatory diet, lifestyle, and really thinking about what goes in and on your body and the world around you. You have a higher likelihood of not ovulating, and so might need ovulation induction medication like letrozole. Some patients with PCOS need IVF, and sometimes they benefit from medication to improve insulin resistance, which can be metformin, it can be inositol. We also see weight gain associated with that insulin resistance. GLP-1s have been great for this. I also see high testosterone levels causing some undesirable symptoms, which can be treated with other medications like spironolactone, things like acne and hair growth. Now, if you are not on birth control pills and you're having perfectly regular cycles, I wouldn't do anything about it. I would make sure that we're checking other associated hormones to make sure you don't have insulin resistance, but I wouldn't just treat anything. If you're on birth control pills or you have an IUD and you don't know how your periods are, that's a circumstance where you should know you might be at a higher likelihood of having irregular cycles because of this AMH, and you might want to stop that birth control method 6 months at least before you want to get pregnant, just so that you allow your body time to see what it can do and if you have a regular ovulatory pattern or not.
Hi, Dr. Crawford. I'm kind of new to fertility testing and treatments, and your podcast has been super helpful. But my question is, I am 33 years old. Me and my husband have been trying to conceive our first child for about a year now. We did have one miscarriage back in May and have not had luck getting pregnant, so I went and got all my baseline labs taken at cycle day 3, and I have a antral follicle count of 9 and an AMH of 1.24. From what I've read, I have not discussed these results with my doctor yet, but from what I've read, these are below average. I would love to have a family of more than one child, but I would be so happy to be blessed with a child at all. Do you suggest that I go straight to IVF instead of trying IUI, and also how many egg retrieval cycles do you think it would take for me to get an adequate amount of embryos to be able to have a family of more than one child? Thank you so much for all you do for the community.
Great question. Lots of different moving pieces. Let's just go through a few of it. AMH of 1.2, follicle count of 9, these are low. I would think with that AMH, your follicle count could vary, I would say anywhere from 8 to 12 based on the month and based on what could happen. Now, your age is really good here. 33 is a good age that reflects good egg quality. Even though we have low ovarian reserve, that does not always correlate with poor egg quality. I think you need to decide what is our real goal. And I think you have, but just what people should think of in this circumstance. Getting pregnant with IUI could be wonderful. Yay, you get pregnant now. You might have a harder time getting pregnant with your next kid. And our fear is that IVF, when you have even lower eggs than this and more of them are abnormal, is going to be harder. If you have the ability now, doing IVF is going to help you get pregnant faster and help you have a higher chance of having that second baby. So these are circumstances where I like seeing young patients because we can change the trajectory of your course. Your entire future story may have the opportunity to be rewritten. How many embryos you need? So even though you're young, I recommend genetic testing of embryos if part of our goal is to save them for the future. Not every genetically normal embryo will turn into a baby, so one embryo has about a 60 to 65% chance. Cumulative rates of success after 2 embryo transfers is about 88%, and after 3 is 95%. So that means we really like to have 2 to 3 genetically normal embryos in the freezer for a future child. This is a circumstance where I would tell somebody, I want to have at minimum 4 normal embryos before we move on to an embryo transfer. If you get pregnant in that first embryo transfer, then you have 3 others, and that's a 95% chance you'll have another baby. If you don't get pregnant, we can make the decision, do we do a second transfer, leaving us with still a good chance at 88%, but accepting that that is lower than 95%. Or sometimes we intervene and we do an additional egg retrieval right now. Because if you're pregnant from the cycle, you've got to gestate the baby 9 months, give birth, heal at least 6 months before we can go get eggs again because your ovaries have to be low enough in the body. So I usually say this is a great place to think of a goal at minimum of 4 normal embryos. If you wanted 2 kids and you were not ready to try right now, I'd really want to get closer to 6 if I'm not doing more cycles, if I can't get you pregnant soon. The short answer, the more you have, the better your future set up, but having a lower egg count is going to make each cycle a little bit harder. Average numbers, let's just use 10 because it's a round number. If I was able to get all 10 eggs to maturity, which sometimes you can't get them all, remember we're going against what the body wants. But if we can, then let's say normal fertilization is about 75 to 80%. Let's say 8 out of the 10 have fertilized. From there, about half of them typically grow out to blastocyst. So let's say 4. And we would expect at least 50% to be normal based on your age. So that would be 2. Remember, not everything falls average. Average means people do better, people do worse. But this would mean I would expect at least 2 cycles to get to our goal, maybe a third. If you mentally prepared for that and then you hit it out of the park in 1 cycle, awesome. Awesome sauce. But I would mentally prepare for 2 to 3 cycles and getting at least 4 euploid embryos in the bank before starting your transfer journey. Of course, plans are dynamic and they change based on how the cycle goes or getting to a reason why your AMH might be lower. But this is a case where intervening now can really make a huge difference. And I'm so glad that you're advocating for yourself now and for the future. I hope this episode helped you guys understand a little bit about ovarian reserve and testing and decision making, what high and low values mean, and what they don't mean. Remember that you can ask questions online at nataliecrawfordmd every Monday on Instagram. You can also ask and read the answers on the newsletter, nataliecrawfordmd.com/newsletter. And you can call the As a Woman voicemail yourself, 657-229-3672. We are almost at 200,000 subscribers over on YouTube, so don't forget Natalie Crawford MD. Go check out our short educational videos there. As always, thanks, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at Natalie Crawford MD and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.